So I'd like to welcome you to the first ABOG podcast. I'm Amy Young. I'm the Executive Director of ABOG, and I luckily get to be the host of this webinar today. We're going to talk about complex family planning. For those of you who don't know, complex family planning is a science and a practice of obstetrics and gynecology in which complex contraceptive care is provided to women with significant medical issues and medical complexities. It's also how unintended pregnancy is studied and cared for, as well as the provision of abortion care and overarching deeper knowledge in contraceptives. And so I am so enthusiastic today about my panel. We are very lucky to have these individuals here. They have been giants in the field of complex family planning. And so first I'd like to introduce Dr. Uta Landy, who's here to my right. So Uta is a global leader in reproductive health care. She has won almost every single honor that there is to win in the family planning field. And moreover, she led the National Abortion Federation and really standardized abortion care. She's also been known for amazing educational programs. I have been the lucky recipient to be able to be engaged with Uta and involved in starting some of these programs. So she built the Ryan Residency Program and the Fellowships in Family Planning, which were essential steps in actually moving the field forward to the stage that we're in now with complex family planning. And to her right is her lovely spouse, Philip Darney. Philip Darney is the Distinguished Research Professor Emeritus for the Departments of Obstetrics and Gynecology and Reproductive Sciences at the University of California, San Francisco. He is also the Director Emeritus and Senior Scholar for the UCSF's Bixby Center for Global Reproductive Health. Over the last 50 years, Philip has served as a scientific advisor and the field evaluator to the USAID, the CDC, and many NGOs. And so we're so lucky to have him here, and we're so lucky to have all the science that you've helped bring forward in this field. And lastly, but not least, I'd like to introduce Dr. Courtney Schreiber, or Corey, as we know her. One of the things that distinguishes Corey, and why I'm so glad that you're here today, is she was the first chair of the subspecialty division of complex family planning. But moreover, the amount of work that you did to bring the subspecialty to fruition, working on the committee that got the passage through ABMS and the ACGME was really huge. So Corey is a Stuart and Emily Mudd Professor of Human Behavior and Reproduction and the Chief of Family Planning at the Perelman School of Medicine at the University of Pennsylvania. There she serves as the Director of PEACE, the Pregnancy Early Access Center, where clinical care, research, and teaching are integrated to advance patient-centered family planning and early pregnancy care. She really strives to improve the health and welfare of all patients, but is particularly focused on those that are underserved and underinsured. So I'm so grateful for you to be here today with us.
Thank you, Amy.
So let's just start our chat this morning, okay? You're all here for a reason, and you're here to really tell the story of where we've come from in complex family planning and where we're going. I mean, you guys have been giants in the field and have really brought complex family planning to where it is today. And so I want to talk a little bit about how we got here and really where we're going, because I really want the world of OB-GYN and actually the larger world to actually know what this means and, really where we're going. But for you two, it hasn't been easy. I know that you guys have persevered through quite a bit to get the field to this particular point. So I was hoping that you would talk to us about some of those really banner days or those milestones where you felt like, we're really going to make it, and what were some of those initial steps that you saw a way forward and were able to get to the point where we are today?
First of all, and the most important part was that we had this vision from the very beginning. When I started taking this on as a program, we had this very clearly defined vision that we were going to move toward official subspecialty. And we kept that in mind all of the time. And so what that meant is we had to make ourselves known to the field. We weren't anybody. Nobody had heard of this subspecialty in family planning. In fact, when I talked with department chairs, about it, they said, what are you going to do? What is this going to amount to? You know, just to take out a pregnancy, that's not such a big deal. So it was very, very important for us to establish our credentials, to establish our heft as a new subspecialty. And so we went through these various steps to get there. For example, we needed to establish the guide to learning and the general and special requirements. And we were very lucky because we got the help and support of those who established the other subspecialties, in particular REI, Dr. Dan Michel, for example, from USC. So we established the structure, you know, to be considered a subspecialty, and we needed to establish the numbers. There were expectations. You know, we talked with 3 generations of leadership of ABOG over those years to understand what the expectations were, and one of those were the numbers. And so we needed to reach out to the department chairs and be visible at all the big national organizational meetings like ACOG, APCO, CREOG, AGAS, and so forth, to give presentations and to show what we were doing and how important it was, and to highlight especially the research that was coming out of our field and how important it was to create this new generation of experts in our field.
In addition, it was clear that the research wasn't being accomplished for abortion, and that the role of reproductive endocrinologists in contraceptive research was fading. 3 of my mentors, Dan Michel, Uta mentioned, Leon Sparoff, Ken Ryan, all reproductive endocrinologists who had contributed to contraceptive research, but the growth of IVF, assisted reproductive technology, meant that the people they were training as their fellows were no longer doing contraceptive research, and abortion research hadn't been done because it had not been related to academic hospitals and medical schools. Mm-hmm. So those were 2 areas where it was obviously important to develop a cadre of young people who would be well informed and do research that could be published and advance the field, because family planning is clearly critical to women's health.
Our listeners probably don't realize that to be a subspecialty, you have to basically prove that it's a distinct science and that there's a population of individuals to be benefited. And it sounds like, you know, what you're explaining is you saw that there was going to be a gap, or a gap was developing, and this is what needed to be put in place in order to fill that gap. That's
right, Amy. For abortion, there never had been systematic research accomplished in the United States. And for contraception, the interests of reproductive endocrinologists in that subject had been redirected.
And for abortion, there was also no systematic clinical training through medical school or residency programs. So it was very important to bring this particular field, termination of pregnancy for various reasons, to bring that into the academic setting and to make sure that the future practitioners in the field had the competencies that they actually needed in terms of taking care of their patients.
I think it's just was so critical that you both had that insight and that series of insights, right? Because I think a lot of people in academic medicine weren't really looking under the hood the way you both were. And to recognize the counterfactual. So what would the world look like today? What would our country look like today? Had you 2 not had that insight and acted on it in order to fill those impending gaps and those long-standing gaps in terms of advancing reproductive health care for Americans and for women globally? That was the key insight that you acted on, and the wherewithal and your ability to communicate that with others. I mean, I even remember the days when people would say, you're going to go do a fellowship to learn how to prescribe birth control pills? Why do you need to do a fellowship to do that? That was the attitude. And that was what you really had to overcome, to recognize the importance of advancing that science. And look at what's happened since then. We have many, many new contraceptive technologies on the market that the fellows, the people you trained and built, the careers that you facilitated, contributed to those newly approved contraceptives on the market today. The choices are infinitely more than they were 30 years ago, right? And abortion care is safer, and there's been innovation in abortion care, enormous amounts of innovation that have actually saved lives in the current environment that we have. So, you know, if you think about what the world would look like had Doctors Darney and Landy not done the work that they did, it actually gives me chills. Like it terrifies me to think what the counterfactual would be if you hadn't done this enormous amount of creative and sustainable work that you did.
You know, your perseverance is truly amazing, and that's what I want to talk about, because I would really like our, you know, listeners to understand that it wasn't always sunshine and roses. You know, sometimes it's, you know, 2 steps forward and a step back. Are there any memories that you have on this journey that, you know, really were pretty big hurdles or barriers, and how did you kind of sustain yourself and support yourself to get through some of those?
Well, I'll comment on Corey's observation that some department chairs, I recall Uta telling me that one department chair who she was wanting to encourage to start a fellowship, and it wasn't easy to get them started at first, these fellowship programs, said, well, I'm really disappointed that one of my best residents is going to join your family planning fellowship. I sure wish that resident would go into a legitimate subspecialty. So as you say, Corey, we needed to overcome the idea, well, there's really nothing that needs to be done in this area. We're doing that already. And as you've observed, there was a lot that needed to be done. And an example is the frequency with which your work, for example, with mifepristone, has been cited in court cases, in political discussions of abortion and treatment of pregnancy complications.
So now to your question, Amy. Obviously, one of the obstacles from the very beginning was or continues to be, the political controversy surrounding this field. So in addition to all the other questions that we had to face, we had to overcome, you know, the reservations by the leadership in the OB-GYN departments, in the teaching hospitals, about what it meant to provide training in abortion and abortion care. And that controversy also obviously affected our applicants. Did they want to get in the field? Did they want to work and, in fact, not just provide services, but be leaders in a field that was always and continues to be surrounded by controversy? So that takes a special kind of commitment, a special kind of passion, a special kind of courage to go into this field and to choose to be part of this wonderful community of our subspecialty. So that was one, the political controversy always there, but there were also points where actually our community, which we had been building up, and it was going very well, started to question whether we should really pursue this subspecialty, pursue this kind of bureaucracy. Things were going so nicely. We did everything. We did site visits. We had standards of care. We had research review. We just put this really good, compelling package together. And why should we go and have this bureaucracy of burden everybody by this bureaucracy of subspecialization? And we would lose a lot by doing that. So that was, I'd say, one of our major hurdles in our journey toward subspecialty, to be able to convince everyone that it was actually, in order to make it sustainable into the future, that is what it needed to that was what we needed
yes,
to do.
Yes, if that was the only way our field would be institutionalized, and it's worked out that way. Many academic departments want to begin these fellowships, while in the beginning, as we said, there was a lot of resistance to the idea.
You know, since I've been relatively new to the board, understanding, working through the process of subspecialty certification with another group, the institutionalization of the subspecialty is a hugely important component, because it essentially helps create a standard of care. It also helps create a standard that a subspecialist must meet, and it's frankly it's a bar that it would be just common parlance if you think about the language used for safety and quality, right? You know, standardization, decreasing variation improves outcomes. We all know that. But understanding it on sort of the mega level and why it was important to move CFP, you know, why not rest on your laurels and keep pushing for the subspecialty certification is really important. I'm going to shift gears a little bit. I'm going to pick on Corey for just a second. And you know, you're the future, and there's been so much work done to get to this particular point. Now we have, you know, regionalization due to legal restrictions on abortion care. What are some of the other sort of hurdles or barriers that you see before us that we should watch out for as we continue to move the subspecialty forward?
Well, I think Uta and Phil set us up so well to continue to be innovators, and that the cadre that they're really responsible for building, and then really as you say, the sort of standards, the expectations, and that honestly that stamp of approval that comes societally with becoming a formal subspecialty positions all of us really well to take on whatever is coming our way. Well, you asked me about hurdles, but I'll first say what I think is a major advantage. And I think a major advantage is, I mean, the two of you could never have imagined where we would be politically. So of course, as you say, this sort of the controversial component of this is has always been there. That's not new. But the regional struggles that are happening now, and the adaptability that that's requiring from providers, from subspecialists, from specialists who have to make decisions about when to refer, et cetera, who are delivering this care, really mandates that we continue to be nimble. And to me, it means that the subspecialty is needed more than ever. First of all, we're seeing all kinds of complications happening to women across the country, preventable complications based on political interference in healthcare, and who's best suited to care for those complications? It's people who have the training in complex family planning and have that subspecialty training. So really now more than ever, we're called to do this work and to problem solve, which is really what the two of you taught us, you know, how to navigate challenges, to bring people around a table, to find the path forward. We have to find the path forward. Again, these are actual human beings' lives at stake. So this is what we're called to do as physicians, is to help people when they need our help. And so, you know, tons of hurdles that are happening currently, that are on their way. But I think we have, thank goodness, a well-prepared workforce to manage all of that. And part of it, I think, also is thinking creatively about where are the bridges and where are the next kind of areas of care that we need to fill and need to pay attention to. So, for example, expanding our knowledge and education and expertise in miscarriage management, in post-abortion care, and contraception, prevention of these complications becomes even more important than it's ever been. So, so I'm so grateful that we really have the workforce, the tools, the pathway to follow set by you to figure out how we're going to navigate this very complicated time for women in America.
And we, Corey, or Uta and I, are so grateful to have this community.
Yeah.
It's built up, and now with marvelous leaders who, like you, completed a fellowship and went to their institutions, often prestigious institutions like the University of Pennsylvania, and built their own programs that have contributed so much to the science and education and training, as well as patient care.
It's the leadership that we were talking about before. So it's not just technical and research opportunities and mandates, but it's the leadership that we often talk about. And the leadership is obviously expected in all of the subspecialties, but I'd say in ours, it's absolutely essential. And we haven't actually published anything about this, but I'd love to see us documenting the incredible leadership that has grown out of our subspecialty.
But you know, what has been published, you know, I think that even though it maybe is not coalesced in one publication, when you look at what happened in the pandemic, and that abortion is health care was sort of almost termed during the pandemic, because it's essential health care, I should say, and that to a large degree was due to I think the partnership that the stage where we were with integration of family planning into complex family planning and becoming an ABOG subspecialty. Again, imagine the counterfactual. If all the work that you had done over those decades had not occurred, do you think that anybody in all the major national medical organizations would be saying abortion is essential health care? I don't think so, because we wouldn't have had the leaders at the table. This type of care has got to remain available and is not elective. I mean, that was an enormous cultural shift for our country.
Absolutely.
And I think it really was because of everything you said, Uta, like going to all those national meetings, building the cadre of leaders, and influencing how people who run these organizations think, and allowing them to understand that this is life-saving, pivotal health care that has got to remain available regardless of the stressors that are going on.
You know, I think that there's often misunderstanding really of the board's role. You know, the board, we are a certifying body, a not-for-profit certifying body, but we certify based on evidence that is grounded in science. And so the advancement of science and family planning is critically important, but we don't regionalize our certification. Because we have an expectation that this care is essential, and you know, we're going to continue to do that. And I think that's the stance that the board has had, and that's really the stance that the board is going to continue to have.
May I just say something about the board too, the role of the board, having worked with the board over a period of about 20 years, there was enormous development in terms of support and openness. There were some particular board members, ABOG board members, who were very supportive and who actually helped us move things ahead and guided us. But there was also reluctance to get involved and to really embrace this field as an official subspecialty. And for ABOG to have evolved to the point of that leadership also among the other organizations is been absolutely essential, and we're very grateful to it. So,
can we talk a little bit about practice? So I'm a specialist or a generalist, depending on who you ask. The board term for it is specialist. So I practice full scope OB-GYN care even today. I have been an abortion provider in the past. And so I wanted to talk a little bit about the relationship of a CFP fellowship trained, board certified individual and a specialist. You know, what does that look like in sort of a perfect environment? I understand that there's variations that will exist sort of depending on where you practice and, you know, sort of what the density of folks look like. But if you could describe, for example, sort of what that perfect interaction would look like, what would it look like to you?
Thanks for asking that, Amy. I mean, access to abortion and contraceptive care, and even, you know, in our blueprint, it also includes, CFP includes more generally management of early pregnancy complications, complex ectopic pregnancy management, early pregnancy loss management as well. Those are the most common needs of females of reproductive age. So we need everybody to be participating in the delivery of that care. And so specialist engagement in the delivery of that care, I mean, truly, the basic delivery of contraceptive, abortion, miscarriage management, ectopic pregnancy care is bread and butter gynecology. And so specialists providing that care to their patients is so critical because many of these are time-sensitive needs. Access issues are a huge problem in our country for gynecology. I mean, in my own city, we have a multiple 1,000-person wait list for gynecology care, and I live in a major city, in Philadelphia. So, I mean, access issues are a real challenge for us. So having a diverse workforce delivering the care is really important. And referral to subspecialist can happen for any number of reasons when for X, Y, or Z reason, this particular patient's presentation or the situation is outside of the comfort zone of the specialist. And that's really what we're here for. And so that reason for being outside of the comfort zone could be a surgical history reason, a medical history reason, or in our field, it could be a regulatory or legal reason. And so, you know, we're happy to take those patients, delighted, that's what we're here for, to take those patients when for any number of reasons the specialists feel that they're unable to care for them as well as they would like their patient to be cared for. So I think that's really the relationship.
I think that is such a great clarification. You know, some people worry with, you know, future subspecialization or even the subspecialization that we currently have, that there'll be someday that'll end up being a credentialing issue for providers. And so I think making that very clear that we all need to be there, we all need to work together. Depending on some of those factors that you mentioned, that relationship may vary, and that's okay too. But understanding that we're all needed to provide services, and I think is really important. So I think that we have just a few minutes left. So I wanted to give you each the opportunity to let our listeners hear from you with one parting thought. What do you want to leave with our listeners today? What's most important to you, and what's kind of your burning platform? And I might pick on you first, Corey, this time.
Well, I'm honestly just so honored to be here today with all of you and to have the opportunity to sort of remember and reflect on the history of the subspecialty and the enormous, as you said, Amy, persistence, creative work that was required to get to this point. And I'll repeat myself by saying that when I imagine the counterfactual, I find it actually terrifying. So to me, it's following your example, you know, that anybody listening to this podcast, there's so many areas that when you peek under the hood and you really get into the weeds and think about that, that finding that passion, whatever it is, to improve the outcomes for the population and for individuals, we all can, find that path for ourselves. And first of all, it makes for a very rewarding career, right? Because doing the same thing every day gets tiring after a while, gets boring, honestly. So if you can figure out what it is, the way that Doctors Landy and Darney did, that are going to really continually challenge you to come up with new ideas, to interact with new people, to spread your message, that makes the work more rewarding, and it also changes the way we deliver care for people in the future, which is an amazing, enormous contribution. Nobody could possibly ask for more, right? So I think that is sort of what I would say is that it only took for you both observing. You were paying attention. Mm-hmm. Dr. Darney noticed that REIs were no longer investing their mental energy in contraceptive technology development. Somebody has to pick that up. Who's it going to be? Dr. Landy noticed that it was going to take a certain kind of gentle pressure political savvy to really figure out the pathway forward to keep, honestly, abortion care available and reintegrate it into academic medicine, which is what you did. So those observations and then figuring out, like, what is the deliberate, well-planned, well-thought-through patient path forward to get it accomplished? I think those are the lessons to learn.
When I think about what you just said, it's this thing that I think is really innate in most of our diplomates, and that is that they have intellectual curiosity, and they continue to grow and develop and reach toward mastery through their whole careers. You guys did it on steroids, is what I would say, right? You took it to the nth degree, but I think it can even be boiled down on as a way to motivate the diplomat on even the littlest level, right? Why is this happening, and what can I do about it? So Phil, what do you think? If you had one thought to leave with our listeners today, what would it be?
It's how important building a community is. I'm so proud of the fellows I have trained and my colleagues have trained who've gone off to start new programs, do their own research, and at the way they communicate with one another to improve teaching, improve patient care, and collaborate on research. So the whole experience over these 30 years has really been rewarding to me to see this growth.
So Uta, you get the last word today.
I get the last word. That's so nice. Thank you for the last word. Well, I would say that times are tough right now. They are difficult, and I think some people get discouraged about it. And I hope that the community that we have built up and the next generation and the next generation that will come because of what we have accomplished will continue with the passionate commitment to women's health and to standing up for our field and for the health of women, and not to be discouraged, to continue to be brave and not intimidated, and to be, as I sometimes half-jokingly refer to as our army. I think I'm hoping that will continue.
Well, thank you all so much for being here with me today. I think we are so fortunate to have been able to gather this group together to have this conversation. So again, I'm Amy Young, and this is Talking Women's Health with ABOG today. So thank you guys for coming.
Thank you.
Thank
Very
you.
welcome.